Okay. It's definitely wonderful to touch base, and I know one of the favorable things from this whole pandemic is I think some of these Zoom lectures and things have provided us opportunities to sort of discuss and work together, and also improve our educational platforms for a lot of healthcare professionals. So I'm privileged to be part of this lecture and to speak to you today. And in terms of what I do, I'm a surgical oncologist here in Tampa, Florida. I do a lot of kidney cancer in my clinical practice, and I typically, on an average year, do about 150 to 200 nephrectomies. So a lot of what I'll be speaking to you today is relating to the surgical management of advanced kidney cancer, but specifically focusing on tumor thrombi management. And definitely happy to answer any questions or have discussions which may not necessarily reflect this topic as we sort of wrap up near the end as well. My disclosures have no financial disclosures. I do serve on several committees for the NCCN and other societies. So just to go over classification of tumor thrombuses, as you all know, kidney cancer is somewhat of an unusual tumor in its ability to get into the vasculature, particularly the venous vasculature. And this is what's called the Mayo classification, or the Neves-Zinke classification of tumor thrombuses, and it really reflects how high ultimately the tumor thrombus goes. So if you have a tumor thrombus which extends into the vena cava, so beyond the ostium, but less than 2 centimeters within the vena cava, that's classified as a level 1, versus if it extends beyond 2 centimeters but not into the liver, a level 2. If it goes into the intrahepatic IVC, a level 3, and then obviously if you have an intracardiac component to it, a level 4. This is an article we had written a few years ago, and this just illustrates again that the care of advanced kidney cancer, particularly tumor thrombosis, is multidisciplinary. And what I mean by that is it's not simply only the surgeon. It takes a dedicated team of very talented anesthesiologists, potential other surgeons like hepatobiliary surgeons or cardiac surgeons or vascular surgeons. And so really, when a case is identified that there is a tumor thrombus, really you have to personalize the approach and understand, are you going to need additional colleagues involved? You have to plan it out with anesthesia, including blood products being available, including the use of sometimes transesophageal echocardiography, which we'll talk about, and various vascular techniques may be required to be used for the surgical approach. This just reflects the fact that what we see is, and this is based on a publication from approximately a year and a half ago, is when you look at volume of cases, you see that higher volume centers typically will do higher level tumor thrombi. So there is a referral pattern of more complicated case to certain centers, is what we notice in North America, for example. And what we see as well is that the mortality risk is significantly less the more of these cases you do. So higher volume of cases, typically lower volume, and it probably reflects that there is dedicated teams of colleagues that are managing these patients at most of these centers. So again, you see that for the various levels of tumor thrombosis, and whether you do 30-day or 90-day mortality risk, clearly there's differences there. Also, what you see here is that the proportion of patients surviving really, again, is highly reflected by the volume of cases. Now, people always ask me, what's a high volume thrombus center? There's no absolute number. Some people use, whether it be 20 or so cases per year as an institution, probably somewhere around there would be defined in North America and many parts of Europe as high volume centers. We see this also for the level of tumor thrombosis. You see for a level 3B, so again, tumor thrombus below the diaphragm, you see outcome makes differences. For 3C, less so in this data set. And we see clearly also in metastatic versus non-metastatic setting, there are differences. Now, this was a nice paper that was just published about a year ago as well. And it really, again, sort of emphasizes this important point that for advanced kidney cancer, it's critical to consider approaching this in a very systematic fashion and often using transplant type techniques. And we'll talk a little bit about what some of these specific principles are in terms of how you surgically approach it. But again, you see that when these are done at centers where there is a dedicated team and using specific techniques, blood loss is significantly less, and ultimately patients do better. Use of cardiopulmonary bypass and kidney function of the patient before surgery also is associated with how patients are going to do. I will tell you, and this is very clear, when you do have to use cardiopulmonary bypass, clearly sometimes you don't have a choice. You may need to use it, but we clearly know when you do cardiopulmonary bypass, there's a much higher risk of complications and potentially mortality associated with it. And if you sort of take that, so cardiopulmonary bypass utilization, and also a patient with poor renal function before surgery, you see mortality risk that goes up to 25%. So up to 1 in 4 patients, even at high volume centers. And again, looking at the outcomes at this in this series versus others, you clearly see very favorable outcomes, particularly for patients who were approached in a very dedicated and meticulous fashion, with lower blood losses typically, and lower transfusion rates, and ultimately better outcomes. Now, this is an important concept that I always emphasize to people. Is I'm going to sort of now talk a little bit about some of the practical things when you do tumor thrombus type cases. Is that intraoperative TEE, or transesophageal echocardiography, is, as you know, is you put a ultrasonic probe into the esophagus, and it allows you to assess the heart. And oftentimes this probe can be brought down even further to even look at the IVC a little bit lower down, intrathoracic, or potentially intrahepatic. So sometimes it can tell you how much tumor thrombus you have in the vena cava within the liver, for example. And this is typically what you see. This is the vena cava. This is what a thrombus within the lumen looks like. And sometimes it can tell you where it is related to the hepatic veins, for example. And clearly, those are all important considerations. This is a patient of mine from a few years ago. You clearly see here a very large right-sided renal tumor. You clearly see this is the vena cava. You can clearly see there's significant tumor thrombus within it. This is the vena cava, and you can see not only tumor thrombus within this area, but what we specifically look at, and this is an important point, is I tell all my trainees is you have to start looking at the technical things, meaning do you see that there's a clear lumen or basically a plane between the caval wall and the vena cava. Now, sometimes, as you all know, you don't know until you're in the operating room, but sometimes it can help you identify if you think you're going to have to replace an IVC or put a patch, or sometimes if it's a little lower down, you may just simply ligate the IVC. Also, when you look at these films, look for example, is there a thrombus going into the contralateral renal vein, into the lumbar venous system? So those are all important things that it will help you guide when you're doing the operation, that you do the right operation, you resect all visible disease. So these are two principles which we were talking about previously that are taken from a lot of the transplant literature, and also truthfully in a lot of our surgical oncology colleagues' literature. So the Cattell-Braasch is the typical approach we take when we do, for example, a RPLND, or retroperitoneal lymph node dissection. So the right paracolloid gutter is mobilized up to the cecum and the terminal ileum, and so you then reflect the mesentery towards the left upper quadrant up to the root of the mesentery, and by doing that, you're able to flip essentially all of the bowel, get it out of the way to see your greater vessels, your vena cava particularly, and your aorta as well. So this is particularly useful when you're doing a tumor thrombus, for example, to get access, particularly for right-sided tumor. Now, sometimes you may use the modified Maddox maneuver, which is a little different, where the spleen and pancreas are mobilized, and by doing that and flipping them, you get access to this critical area here where you have the aorta. You can see the splenic vessels in addition to the hilar vessels, and it really gives you excellent access to that left upper quadrant to make sure you resect and you have very good visibility when you're doing this, particularly when you get into this area they call the crus or the retrocrural space, which can be challenging to access. This is also an important consideration, is sometimes you have a tumor thrombus, so the vena cava again here, right renal vein here, and you see that these short little veins called these short hepatic veins. So they're very small, they're very meticulous, they're early little small veins originating and entering the liver. So sometimes you have to be very meticulous, control these, and ligate them. And as you're doing that, you're able to get additional mobilization on the liver. Sometimes that can potentially make it such that you could get access to the vena cava within the liver segment without having to necessarily completely mobilize the liver or get suprahepatic caval control. Now, also, this is from one of my cases. You clearly see there's tumor thrombus here. Sometimes I like to remove the actual kidney before I actually start the thrombectomy. The reason being is sometimes the kidney's so bulky, it's in your way, and it makes it just challenging to do. And I often tell people if the lumen of that vessel is quite large, sometimes I prefer using clamps versus actually using staplers, vascular staplers. I know some parts of the world, these are very expensive and may not have access to them. The staplers sometimes don't work very well when you have a very thick vessel or when you have clearly thrombus, for example, within a vessel. So sometimes getting it exposed in this way really gives you excellent access and mobilization. So here's some other additional surgical concepts. First and foremost, I tell people, because I see this in practice, is whenever you have a thrombus case, I know some medical doctors and colleagues say, we're just going to put a filter. Not a good idea. Why? Because sometimes that filter will be literally in your way when you're doing the thrombectomy. So oftentimes I tell people you want to avoid getting access or putting a filter in that specific space. So sometimes these are called DeWeese clips. Sometimes are used or they're placed before the cases to try to minimize the risk of thrombuses migrating. Again, avoid those. Sometimes if you're concerned, for example, a patient has active pulmonary embolus, you may decide to anticoagulate them for a period of time. Sometimes these filters can be put above where you're going to be working so it doesn't interfere with your access. And again, relating to some of these vascular techniques we use, sometimes a Fogarty balloon is a very useful tool which you can put in a vessel to get the thrombus and get it out. Particularly, for example, if you had a thrombus that was in the vena cava but extending into the left renal vein, using a Fogarty may allow you to get that thrombus into the vein out without necessarily having to make an extended incision within the vein itself. And sometimes, again, when we're saying about if you have a patch of the blood vessel that's involved, you may have to put a patch graft in that area to control it and to sort of get not only the thrombus out, but also get the cable wall that's involved out as well. This is a technique called veno-venal bypass. We do use it sometimes in selective level 3 tumor thrombosis. So let's just say you have a thrombus which is going into the intrahepatic IVC. The concern is once you clamp the vena cava, obviously you're decreasing the volume of blood getting to the heart and getting to the vasculature. So sometimes what you can do is by doing veno-venal bypass, you're basically getting some of that venous blood back to the lower circulation and maintaining it throughout this point. What happens from that is sometimes it's felt to get less of shifts of fluids and hypotension, and that may ultimately, in particular in a patient who has medical conditions, may decrease the morbidity of the surgery. Again, this is a diagram of what a veno-venal bypass access looks like. In many ways, veno-venal bypass is similar to cardiac bypass in the sense that it's pass-through machine, and oftentimes we'll do these types of cases with our liver surgeons just because they often do them in liver transplants. So this is a case of cardiopulmonary bypass. This is a thrombus I did a few years ago. As you see here, full chevron was done to get access to the abdomen and get the tumor out. And then usually the coordination of this is critical. Oftentimes I tell people, if you have a large amount of thrombus within the atrium, we will have the anesthesia colleagues put that TE probe early in the case for us to know what's happening real time throughout the surgery. And usually with the cardiac surgeons, we have the chest ready prepped so that once the tumor is out, we can get on bypass fairly quickly. You don't want to be on bypass too long. We clearly know the longer bypass time you have, the more morbidity and potential complications you have for patients. And this is that thrombus we took out. This patient here had a large amount of thrombus in not only the right atrium or the right ventricle. This is the survival curves from a publication for tumor thrombosis. And this is to highlight the fact these are highly morbid surgeries. These are not surgeries that I tell my patients you're going to go home in 2 days. You have to understand there's risks of mortality associated with it, particularly if patients are not optimized. And you clearly see the level of performance status. So if a patient is deconditioned, like a level 2, oftentimes we try to optimize patients such that they're not having surgery when they're in ECOG 2. Often ECOG 0 or 1 are really ideal states you want to have your patients, because clearly, as you see, if you have a performance status of 2, your survival is about 6 months. Sometimes you can't get those patients any better, and sometimes you have to ask yourself ultimately, in those settings, do you want to give these patients medications versus go ahead with a pretty morbid operation? Again, when you start looking at tumor thrombus levels and how patients do, and this is our data again, you see once you have to go on cardiac bypass, the morbidity of it goes up fairly dramatically. Again, there's no question when we looked at tumor thrombus, again, level 4 is a very unique group, median survival of 10 months. So definitely a point of reflection that I say to our patients, you need to be aware ultimately. This is a fairly high morbidity, high mortality surgical risk. And again, that's in even centers that do a lot of these cases. This is also very critical, and I think there's a lot of relevance to this, is that if you have metastatic disease, so you have metastatic kidney cancer, this is the survival curves of patients who don't have metastases versus patients who have metastases. And you clearly see patients with metastases do worse. Median survival of only 12 months versus 55 months. And so now, especially with recent studies which show that in the setting of metastatic disease, the benefit of cytoreductive nephrectomy is not clearly shown, particularly in patients who are intermediate to poor risk. Oftentimes, those patients will not have surgery, and I think that's important also to be aware of. We also did these studies a couple of years ago, a multi-center retrospective study of 5 high-volume centers, and we really, again, showed level 4 tumor thrombosis clearly do worse than those who have low-level tumor thrombosis, and the factors that predict how patients do are serum markers like LDH, presence of having symptoms, histology, including sarcomatoid variants being present, and IVC thrombus above the diaphragm clearly, again, will affect how patients are going to do. In our series, you clearly see some of these risk groups, including the MSKCC, also known as the Motzer criteria, the IMDC, and these MD Anderson criteria predict how patients are going to do. Again, in our data, you clearly see patients who have tumor thrombosis into the chest cavity do worse versus others. And again, based on these favorable risk groups, favorable, intermediate, porous, you see if you're porous, you can really question yourself ultimately if you should have surgery in that setting. And again, this is some of the data which I think helps you identify based on these MDACC or these MD Anderson criteria, whether or not you should have surgery. And these are the criteria you could use in your clinical practice to determine, again, in the setting specifically of advanced disease, whether or not you should undergo surgery. Again, looking at these multivariate analysis that we did, these are the factors that predicted how patients do. Again, obesity is actually typically a favorable risk factor, and that's because most of the time patients who are morbidly obese, and it's been shown in several studies, have more favorable kidney cancer in terms of the grade of the tumors and some of the biological pathways by which these tumors progress. Now, in recent years, there's been a lot of interest and adoption of doing robotic surgery for tumor thrombosis and even looking at it for higher level tumor thrombosis. So I often tell people, this has to be very carefully selected. You know, we've been talking about this is already a very potentially morbid operation. And so you really want to make sure you do it right. So Dr. Gill at the USC did a lot of work on this and really showed that it can be done. He did in 25 cases. I do think the way it's approached robotically typically is the IVC part of it is done first, then the kidney part is done afterwards. So very different from the traditional of doing the nephrectomy and then doing the thrombectomy. And only one case was converted to open. Transfusion risk were actually quite very favorable, only 21%, and complication rate was only 17%. So very, very favorable outcomes. So these are the ports. This is for right-sided versus left-sided. Typically 3 conventional laparoscopic ports and 3 robotic ports are done. And this is the port placement that they typically do. This is to show you first and foremost medial access, so cochlearization of the duodenum, access to the vena cava, and then really meticulous control of the vena cava, infrarenal, suprarenal, contralateral renal vein, control of the lumbars very meticulously. Once that's all completed, the renal artery is controlled, and typically the thrombectomy is begun, and by cinching down on these vessel loops and really making sure that it's done in a bloodless field. Also, they've described, I think, a very innovative technique where you could use a Foley catheter actually and put it up into the vena cava to try to milk down some thrombosis, so particularly for tumor thrombosis that are not adherent to the wall, that potentially a little higher, that may allow you to make sure you get all the thrombosis out. My caution with that is, as we were talking about earlier, is if you have true wall invasion, that clearly will not work. And what they sometimes do, in fact, is they use a cystoscope actually to look inside the cava and do what's called a cavoscope or a cavoroscopy to really look within the lumen of the wall, which is also a very innovative technique. And this is actually looking at how this is done. Now, this is one of their cases they did. And look here, what you're seeing here is you actually have cable wall invasion, which is seen. So they had to resect this segment of the wall and they had to put a patch. So obviously, if you're doing these types of things, you have to be very facile in doing suturing. And honestly, this is the type of things you have to have it coordinated with a vascular surgeon or a cardiac surgeon who's comfortable doing this robotically as well. And you have to be able to convert fairly quickly if you have to, because oftentimes if the patients don't do well, they deteriorate very quickly. So for cases of advanced tumor thrombectomies, again, these are some of these techniques that we describe. Last but certainly not least, there's some very innovative research taking place looking at circulating tumor cells. So looking at cells and predicting how patients are going to do and if they're at risk of progressing. And this is some of these very innovative type of techniques, which may help us ultimately better understand when we should use, for example, systemic treatments like immunotherapies versus operate on those patients. And last but certainly not least, this is something which we will be seeing in clinical practice. This was a recent study called Keynote 564 that is currently being completed. It was just reported at ASCO just a couple months ago. So in patients with advanced kidney cancer who are locally advanced, or patients with metastatic disease that was completely resected and having these aggressive features, patients were randomized to getting the drug pembrolizumab, 200 milligrams every 3 weeks for 17 cycles versus placebo, and really to see if there's a benefit of doing adjuvant immunotherapy. So particularly in this setting, patients who have advanced kidney cancer, is there a benefit of giving pembrolizumab? And the study really showed there was a decrease in disease-free survival with giving the drug, so improvement in outcomes. So the big question is, how is this going to impact this specific patient population? So if you have tumor thrombus, you clearly meet the high-risk criteria. So potentially those patients are going to receive adjuvant immunotherapy after the surgery, which may improve their outcomes as well. These are some of the analysis in terms of these risk groups, including it's been shown to work not only in patients with non-metastatic, but also metastatic disease, patients who across the world based on PD-L1 status. And again, performance status is very important as well. On that note, I think the conclusions I have is clearly good surgical outcomes are clearly optimized when you do a multidisciplinary type approach to patients. Use of robotics for these types of advanced kidney cancers is really can have a role, but I think it's really important to select out and to have a high level of comfort with minimally invasive techniques and approaches, and also have a really low threshold for conversion if you feel you're not doing it right, or if the patient ultimately has more concerning disease. And I had no question think that the use of immunotherapies and other systemic therapies will clearly have impact how we treat our patients in the future, in particular with advanced kidney cancer. And as I just showed you, adjuvant immunotherapies, particularly with pembrolizumab and potentially other agents which are currently being explored, may change how we treat these patients after surgical resection. On that note, this is my contact information, including my Twitter handle, my email. Feel free to ever reach out to me if I could ever answer any questions. Or if you want to run some thoughts by me, but happy to answer any questions you have. And again, thank you for the invitation to speak to you today. Happy to answer any questions anyone would have.
Hi, Dr. Spiess. Can you hear me?
I can hear you. Mm-hmm.
Yeah. So this is Abisalam Lama. I'm sorry I'm late. My OR case kind of got delayed. Thank you for the presentation. So we see that it's quite a challenging case even for you guys to manage these patients with IVC thrombus. Unfortunately, we do find patients who have this advanced RCC, and usually some of our patients, they come from the countryside, and sometimes they bounce between different physicians before they get the diagnosis, and sometimes even they don't even come to the hospital for evaluation before they get a mass and a big massive hematuria or something. And in our unit, we do try to operate these patients, and Well, some of our consultants who are interested in oncology also do operate this. And we have a vascular surgeon who's very experienced in the country. So whenever we operate these patients, we do get his involvement also. My question is, I'm sorry, maybe you discussed it and I didn't catch it, but the role of anticoagulation before the surgery. I from our reading that some of the tumor thrombus is a bland thrombus. So would it make it easier? Would it make it easier for us to see on an imaging if we anticoagulate them and evaluate if there is tumor invasion or something?
It's a good question. So, yeah, the imaging studies, if you get a high quality imaging, sometimes they can tell you the differences between bland and true tumor thrombus. So tumor thrombus typically is vascularized, so it'll have some enhancing characteristics when you see it on like an MRI with and without contrast, or a CT with and without contrast. I do think sometimes there is a role for anticoagulation for managing the bland component. Sometimes the bland component of the thrombus is situated distal to the tumor thrombus itself. And technically what we do in those cases is typically do the cavotomy, remove the thrombus, and usually flush the cava and get that thrombus out, and then put some intravascular heparin to avoid clot formation on the cava wall. I do think in some cases, anticoagulant patients for a period of time is not necessarily wrong to do. I see that it's done too much, truthfully speaking. Sometimes at the end of the day, thrombus that's vascularized, it needs to come out, it will never sort of go away. But if you do have truly a bland thrombus as such, then potentially anticoagulation, but then the risk is obviously migration of that thrombus into the chest and potentially a pulmonary embolus developing from that.
So there's a question in the chat. It says, do you use diameter cutoff approximately 3 centimeters to predict caval wall invasion?
Not really. It's more about the characteristics on an imaging study, and that's really where the quality of the imaging makes a difference. So sometimes I've seen thrombuses 5, 6, 7 centimeters, and they just have the characteristics where you see the wall very clearly distinct from the thrombus. And in those cases, you know that most likely you're not dealing with true caval wall invasion. I do think there is a level of underappreciation of caval wall invasion, and it's been shown if you do have caval wall invasion, that's a very poor prognosticator on how patients are going to do. So in questions, if you think that there may be a segment, you're best to resect it and either primarily reapproximate the caval wall, or if you need to put a patch. But again, those cases I think need just planned out a little bit more carefully if the imaging suspects that you do have that invasion present. Something I didn't emphasize too much in my talk, but I often emphasize that point to my trainees too, is when you're in the operating room doing those cases, early arterial, once you're getting towards the hilum, early arterial control and ligation is critical, because obviously, as we all know, the thrombus will oftentimes milk back to some extent afterwards. So sometimes you may have a level 1 thrombus or even a level 2. Once you take the artery, the actual thrombus will milk back a few centimeters, and that potentially may make it a much easier cavotomy, or potentially just a straightforward nephrectomy, and you resect the ostium, for example, of that caval wall.
How many cases do you do per year with patients with IVC thrombus?
Varies. Honestly, it comes in runs is what I tell people. So there's years where I do like 6 or 8 in the span of 6 months. And then sometimes I have a run where I don't do any for 3, 4 months. So as a department, because our department's gotten fairly big, when I came here, we were only 2 of us doing these cases. Now we're 6. I probably still do about 10 a year. I used to do once upon a time about 30 a year. So, and I do think there's merit of many surgeons being comfortable within a large department, just to make sure that, you just never know. Sometimes I've had some cases where the imaging didn't really show it well, and lo and behold, There was thrombus present in the cava that wasn't appreciated. And that's really where the quality imaging is critical. And my advice to everybody is, if you're not happy with imaging, if it's feasible, obviously, to get additional imaging, get that. In some places, I think even an ultrasound in skinny patients, an ultrasound could really give you an appreciation of what the cava looks like intra-abdominally or intrathoracically.
Yeah, I'm asking you this because given that you do so many cases per year, you probably have a very good experience in that. Sometimes it's not, it's because some of our audiences are residents. It's not something to dare to do once in a while, even for where our teaching facility, it's only like 1 or 2 people who are, encouraged to keep on doing the same thing so that they get some experience from it.
No, I agree with that 100%. You're absolutely true, absolutely correct. And I even say, even from the other specialties, from an anesthesia, from even hepatobiliary or others, it's good to have dedicated teams of people that do and focus in these areas. It does make, like we were saying, the outcomes are clear. The outcomes are simply better.
So I think there are no more questions.
Well, I appreciate the opportunity to speak to you. I hope this was interesting and educational, and definitely reach out to me if I could ever answer any additional questions. And thanks, Ashley, for organizing this. And it's always a pleasure to be part of the IVU lecture series.
Yeah, thank you, Dr. Spiess, for speaking, and thank you, Dr. Lima, for coordinating with everybody.
All right, thank you.
Take care, everybody.